Hi and welcome back to the lectures by Dental Amaze Academy. Today I'm going to discuss with you a very important topic, which is CNS infections, and of which the most important is meningitis. Okay, and I'm going to go a little bit into depth and into a little bit of basic understanding. Okay, if you see your MCQ book, you'll see that there is a chart which simply describes neutrophil increases, that increases, glucose comes down. So why and what is the significance of it, and how you can learn it much more better way. Okay, and also a little bit more than what is there in the chart. Okay, so that you can answer any or tackle any questions related to this. Okay, and it's one of the very important infections of CNS which you should be knowing. Okay, there are lots of infections, of which the most important is, I would say, is the meningitis. So initially I'm going to discuss with you a little bit on normal CSF evaluations. Okay, normal values, of which a few are very important and the rest is being given for a completion purpose. Okay, now see, in meningitis, you'll see that the CSF pressure, intracranial pressure, increases. So what is the normal value? The normal value is 50 to 180 mm of water, not mercury. Okay, it's 50 to 180 mm of water. Okay, now CSF volume, now it is not very significant, but just to give you a understanding of CSF evaluation, CSF volume is 150 ml. Okay, 150 ml. Now CSF glucose and CSF proteins, these are a little significant for you, of which CSF glucose is 40 to 70 milligram per deciliter. Okay, it is 40 to 70 milligram. It's going to increase, decrease, remain normal in various CNS infections. In fact, it doesn't increase, it usually decreases or remains normal in various CNS infections. Now about total proteins, it is 15 to 50 milligram. So it's easy, 15 to 50 milligram per deciliter. 15 and 50 is related, isn't it? Now, is there RBC in CSF? No, that is not there. There is no RBC in CSF. But is there WBC? Is there leukocytes? Yes, a little bit. Okay, it says that less than 5 microliter per liter. Okay, less than 5 microliter per liter is there. Now, what is the pH of CSF? It is 7.1 to 7.34. Okay, just again, definitely, if there is infection, there's going to be a kind of acidic nature of CSF and pH can come down. So, but again, it's not a differentiating features between different infections, because overall it's infection, isn't it? Much more significant here is about the CSF glucose, CSF pressure, total protein, and leukocytes, in the sense different type of leukocytes are seen in different types of meningitis. We'll go into details of that as we go on. Okay, now normally the level of CSF glucose is 1/3 of plasma glucose. This is one point which you have to keep in mind. Okay, maybe an MCQ can come. CSF glucose is 1/3 of the plasma glucose. So plasma glucose is how much? 80 to 120 milligram per deciliter. And you have seen here the CSF glucose is 40 to 70. And the CSF glucose is 80 to 120. Okay, 80 to 120. Now let us go on to meningitis per se. Okay, now what is meningitis? Meningitis is nothing but infection and inflammation of meninges. Very simple, isn't it? So it's basically infection and related inflammation. So definitely any infection can bring about inflammation. So infection plus inflammation of meninges. Okay, of meninges. Now one thing which you have to differentiate here is that if there is involvement of brain parenchyma, besides what you have as the meninges, besides meninges, if there is also involvement of the brain parenchyma or brain tissue, then you call it as encephalitis. So just a differentiating term, encephalitis. Okay, now you have got different types of meningitis. There is acute meningitis, there is subacute meningitis, and there is chronic meningitis. We are not going to concentrate much onto the chronic meningitis, which is much more towards systemic diseases like cancers, sarcoidosis, SLE and all those, but we are going to again concentrate on the infections part, okay, which is much more important for you all. So it's acute meningitis and subacute meningitis is what we are going to concentrate on. Acute meningitis, you can see that it's classified into bacterial meningitis, acute bacterial meningitis, and acute viral meningitis. Acute bacterial and acute viral meningitis. Now let us start one by one. Okay, and acute bacterial meningitis is the most common form of suppurative CNS infection. Okay, it's the most common, suppurative CNS infection. Okay, CNS infection, most common form of suppurative CNS infection. Here you have to know an MCQ, which is which part is suppurative, or where do you see what is suppurative means? It's basically pus. So where do you see the pus? It is in the subarachnoid space. Okay, subarachnoid space. SAS is the official short form, subarachnoid, below the arachnoid. We have studied meninges, isn't it? So where exactly? In the subarachnoid space. We have studied pia mater, that matter, arachnoid matter, okay, and dura matter. Dura is on top. So subarachnoid space, in this subarachnoid space where you can see the suppuration. Okay, now about the etiology. Now what you have to know is two very important organisms. One is the Streptococcus pneumoniae, it's the first one is Streptococcus pneumoniae and second is Neisseria meningitidis, of which I would say the most common cause of the CNS meningitis in adults. Okay, so it's different terms you have to know. The most common cause of meningitis in adults greater than 20 years is caused by this organism. Also, the most common cause of community acquired meningitis, like that is in general population, the community acquired meningitis is basically the Streptococcus pneumoniae. Now the most common cause in general, if they ask you, most common cause is Streptococcus pneumoniae. Now one more thing your books say is that the most common cause of recurrent meningitis due to CSF leak. Okay, so remember CSF rhinorrhea can cause, now if there is a maxillofacial injury, you know that in Lefort 2, Lefort 3 fractures, especially in Lefort 3 fractures, okay, not much in Lefort 2, but Lefort 3 definitely, you're going to have CSF rhinorrhea, isn't it? And this CSF rhinorrhea can lead to meningitis. That's a big problem what maxillofacial surgeons face when they have Lefort 3. Okay, Lefort 3 fractures, the patient can get into CSF rhinorrhea. So remember, it's the most common cause of recurrent meningitis due to CSF leak. Okay, due to CSF leakage. Okay, now that was about Streptococcus pneumoniae. Now when you come on to Neisseria meningitidis, we have gone in detail about this in microbiology. Even in about Streptococcus pneumoniae we have got into detail, but Neisseria meningitidis is the second most common cause of meningitis in general. Okay, in general. Now we have a little more to understand, that is other organisms which can cause this infection, which is of which we have got group B streptococci. Okay, group B streptococci and Listeria monocytogenes. So there are much more organisms out there, but you have to concentrate on these two. Okay, now group B streptococci, we've again studied it is Streptococcus agalactiae. Okay, and the thing you have to know here is it's the most common, or it was considered to be the most common cause of meningitis in neonates. Okay, neonates earlier, but still again if it's an MCQ question, you have to go for the Streptococcus agalactiae only. Okay, most common in neonates and most common cause in like older population greater than 50 years of age. Okay, so the most common cause of group like meningitis in neonates is basically group B streptococci, which is Streptococcus agalactiae. Okay, now you can just write it was an old concept. So, but still, I don't think they're going to advance into new concept, because this is given in Harrison, the latest edition of Harrison, which says that L monocytogenes is the most common now. Okay, currently it is being considered. So now, if L monocytogenes is there in the option, you can go for it. Again, question mark. Okay, because maybe I don't know if the person who's asking know it have referred Harrison or not. Okay, so but still, I would say it's like now it's being an emerging cause, the most common emerging cause in neonates. Okay, L monocytogenes. Okay, now see, it's also being the most common cause in pregnant patients. Okay, and immunocompromised patient, and also greater than 60 years, the people who are greater than 60 years. Now see, few very important things. In general, if they ask you what is the most common cause of meningitis, it's Streptococcus pneumoniae in adults, and it's associated with CSF leaks. Second most common is the Neisseria meningitidis. Okay, then you have group B streptococci, which is in neonates, but now the emerging thing is that it's L monocytogenes. In pregnant, immunocompromised, and greater than 60 years, it is L monocytogenes. Okay, now let us go on to the next part, which is pathophysiology. Now this is very important to understand, to understand the chart what you have, and also which is related to the lab diagnosis and clinical features. So let us go into a little bit of details on that. Okay, if you start understanding the pathophysiology, you'll see that initial colonization. So its initial colonization is in which region? It's the epithelial cells. Remember, epithelial cells of nasopharynx. So usually it is being acquired as inhalation. Okay, so it's the epithelial cells, very important, of nasopharynx. Then what happens is it goes into the blood. Okay, it comes into the blood. From blood, now where should it reach? CSF. So it needs an entry into CSF, and the entry is given by choroid plexus. Okay, from the blood it reaches the choroid plexus, and from the choroid plexus it finally and eventually reaches CSF. Now two things which you might get a question: what is the factor, or what is the virulence factor of the bacteria which prevents it from phagocytosis in the blood? Because it is there in the blood, and you know that blood has got lots of immune responses which can phagocytose the bacteria. So what's the factor which prevents it? It is the polysaccharide capsule. It is the polysaccharide capsule which prevents it from what? From phagocytosed. Now it reaches CSF. Now again, is there any factor which is responsible for having a lesser immune response in CSF as well? Yes, that is, it has got fewer WBC. Okay, fewer WBC, and also fewer complement proteins. Okay, fewer complement proteins. So all this will add on to the factor that the bacteria is not killed. It remains alive in CSF as well. Okay, so now what is going to happen? Now this is where the things are going to change. The bacteria is there, it's not causing any problem, but what causes the problem is the lysis of bacteria. Okay, the lysis of bacteria, that is when, especially when you give a bactericidal drugs and all, what happens is that the bacteria gets lysed. Okay, the bacteria gets lysed up. Okay, now when the bacteria gets lysed up, what is going to happen next? It is going to release its cell wall contents. Okay, cell wall contents. So if it is in gram-negative bacteria, it's going to release its lipopolysaccharides. Okay, it's going to release LPS, lipopolysaccharides, or if it's positive, it's usually teichoic acids. Okay, the teichoic acid and peptidoglycans and all those. Okay, so now what is much more important? This is going to cause inflammation. Okay, this is going to release very important factors like cytokines and chemokines. Now this is going to cause inflammation. Okay, this is going to cause inflammations. Now see what has happened so far. The bacteria has come into CSF. Okay, it has released its contents, it's lysed and it's released its contents, and now once its contents are released, you are going to provoke inflammation, because once its contents are released, cytokines and chemokines are going to come there. Okay, and these cytokines and chemokines are going to cause inflammation, and remember, this inflammation is responsible for the neurologic manifestations. Okay, neurologic manifestations, and also the complications or CNS complications which you are going to get. So what is basically causing the problems or inflammation and complication, that is the manifestations and complication, what is actually causing it? It is basically the inflammation which is causing the problem rather than the bacteria as such. Remember this. Okay, it's a concept which can be asked. Okay, not very significant, but this is basically a concept which is need to be understood. Okay, once you're understanding things in detail. Now, what is this inflammation going to do to your body or the patient's body? What is going to happen which is related to this inflammation? One thing is that definitely inflammation, we have studied in general pathology that it increases permeability, isn't it? So it increases permeability. Now what happens if there is an increased permeability? Two things can happen. One is there is going to be an edema, isn't it? There is going to be edema, and also there is going to be the leakage of proteins. Now if you see all the meningitis, you see majority of them, there will be an increased protein, and this is where it happens. Okay, now inflammation, you know, different types of cells come in related to inflammation of different bacteria and different organisms. Bacteria, a typical kind of cells come. For virus, different cells come. For tuberculosis, different type of cells come. So all these are associated with inflammation. Okay, second thing is that inflammation and edema can obstruct the flow of the CSF. So this is going to again increase, or this together with edema is going to increase CSF pressure. So that is why CSF pressure is increasing. Okay, in all types of meningitis there is going to be an increased CSF. Now this inflammatory mediators are also going to produce certain free radicals and things which can cause death of brain cells. Okay, death of brain cells. Now the textbook, the Harrison says very specifically, a specific region is destroyed, that is the dentate gyrus of hippocampus. Okay, dentate, especially the dentate gyrus of hippocampus. Now hippocampus, you know that it is related to memory. Okay, and it is there in the temporal lobe, isn't it? So this is the region where the brain cells are destroyed, that is the dentate gyrus of hippocampus. If someone wants to ask you this question, where exactly the damage to the brain cells occur, besides all those problems associated with edema, CSF, increased CSF pressure, where exactly it is the dentate gyrus of hippocampus. Okay, dentate gyrus of hippocampus. So this is basically what has happened. Now increased CSF pressure can lead to what is known as the cerebral herniation. Okay, herniation, that is the brain or the cerebrum or cerebral region gets herniated, pushed out due to all this edema, inflammation and the things causing related related problems. Okay, so what did we see so far? Once again, a very quick review. What is happening? The epithelial cells of nasopharynx is colonized. It reaches blood. There is a polysaccharide, so it's not causing any problem. It reaches the choroid plexus. From there, it enters into the CSF. Now, here also there is a problem, that is there is no or very few WBC, very few complement factors. So the bacteria is not being phagocytosed. Instead, it gets lysed up, and once it gets lysed up, you will see that yes, there is inflammation, cytokines and chemokines coming there, which is causing inflammation, and inflammation causing all the complications like edema, leakage of proteins, the increased ICP because of blockage of CSF flow, and the dentate gyrus of hippocampus is damaged due to the inflammatory mediator. So this is what is basically the pathophysiology of meningitis, acute bacterial meningitis, which is common for almost all, all types of meningitis, Now, when you come on to the clinical features, of acute bacterial meningitis, you have got a triad. And what is the triad? It is basically fever. There are three things which is very characteristic. Fever or characteristic symptoms. Fever, headache, and nuchal rigidity. Nuchal rigidity or neck rigidity. So definitely all this again related to the pathophysiology. Fever is related to inflammation. Headache is related to definitely increased there is edema, there is all those inflammation things. Nuchal rigidity is again neck rigidity, which is very pathognomonic of the meningeal irritation. If there is a meningeal irritation, there is going to be nuchal rigidity. So if they ask you what is a pathognomonic feature of meningeal irritation, pathognomonic of meningeal irritation, it is basically the nuchal rigidity. Now, it's not over yet. It's going to cause more problems, of which you have got decreased level of consciousness. Definitely all these are related to neurologic. Decreased level of consciousness patient will have. There is going to be nausea. There's going to be vomiting. So all these are very non-specific symptoms. And photophobia, remember this, photophobia. Now, when you go on to the viral meningitis and all, there is no much decreased level of consciousness, there is no much photophobia, and again, there is going to be raised ICP, intracranial pressure, isn't it? There is going to be raised ICP. Now, one more thing, there is going to be seizures. There is going to be seizures. There is going to be seizures, which is focal seizures and generalized seizures. So both kind of seizures are going to be there. So one correction, that in viral meningitis, I told you there is less decreased level of consciousness. There is consciousness is not affected much, and more importantly, there is going to be less seizures. And raised ICP is going to be there, but it is not as high as the bacterial meningitis. So that's how you differentiate clinically between viral meningitis and bacterial meningitis. Not very specific. There is much more to know when you diagnose viral infections, and more it is like CSF examination is much better way of diagnosing viral meningitis. Now, when you come on to the raised ICP, I've told you it is basically greater than 180 mm of water. 180 mm of water. Now, a very important sign of raised ICP, they're saying that there is something known as Cushing's reflex. There is not something known as Cushing's reflex. And this Cushing's reflex is nothing but it is a symptoms of bradycardia, that is decreased heartbeat, hypertension, and irregular respiration. So it's a very important sign of raised ICP, Cushing's reflex, which is hypertension, bradycardia, and irregular respirations. Irregular respiration. So what did we say? We said that there is going to be a triad of fever, headache, and nuchal rigidity. Nuchal rigidity is pathognomonic here for meningeal irritation. Then you have got other features like decreased level of consciousness, nausea, vomiting, photophobia, seizures, raised ICP. Now, something which is related to raised ICP is Cushing's reflex, which contains bradycardia, hypertension, and irregular respiration. Now, I'm going to come on to something which is slightly or equally important, which is the two very important signs which you see, which is associated with meningeal irritation in acute meningitis, which is Koenig's sign and Brudzinski's sign. Brudzinski's sign. Koenig's sign and Brudzinski's sign. Now see, these are the two pictures which I'll explain to you. Let me just explain the first part and then I'll explain this here. Now, how it is elicited, Kernig sign, it is elicited, both of them are related to meningeal irritation. So if they ask you what or which of the following is seen in meningitis, okay, which is associated with meningeal irritation, which is common to all types of meningitis. So it's seen in all types of meningitis typically. Okay, now Kernig sign, what you need to do is you have to place the patient in supine position and thigh is flexed on abdomen. So this is the abdomen, the thigh is flexed on the abdomen. Okay, what is flexed? This is extension, this is flexion. So thigh is flexed on abdomen, okay, with knee flexed, with knee is also flexed. Okay, thigh flexed on abdomen, knee flexed. Okay, then you like passively extend the knee. So you're going to initially flexed it, now you're going to extend the knee. So you can see here there is the doctor is trying to extend it. Okay, when you start to extend the knee, you will elicit the pain, and this is a sign of meningeal irritation. So you don't need to know in detail, but just know what it is. If this picture you can remember, it's very simple. Now basically when it comes to NEET preparation, it's basically nothing but what is a sign and what is the name of the sign, that's it. So it's basically Kernig sign. Now you have got the Brudzinski sign. Again, you place the patient in supine position, it's much more easy. Passive flexion of the neck results in spontaneous flexion of hips and knees. So you passively flex the neck, so again it's flexion. Flex the neck, you see that the patient's knee gets flexed spontaneously. So passive flexion of the neck results in flexion of hips and knees. Okay, so hips and knees gets flexed. Okay, and this is again a sign of meningeal irritation. Basically what you need to know here is Kernig signs, and Brudzinski sign is associated with meningeal irritation. Okay, and it is seen in meningitis. Okay, now besides these symptoms which we just saw now, there is also some specific symptom which you need to know. Okay, there is a very specific symptom which is associated with meningococcal meningitis. Okay, like Neisseria meningitis, so it causes a meningococcal meningitis, and it is basically nothing but rash of meningococcemia. Okay, meningococcemia, which is when a patient gets affected by meningococcal infections, the patient produces rash. Okay, and this rash is very specific, which is even seen in meningitis also. Basically it's nothing but it's a rash plus erythema. Okay, erythema, basically there is an erythema. Now the problem, if you have this kind of a rash, okay, of meningococcemia, which is erythema associated rash, if you are someone who know much about viral infections, you will think that this is a viral meningitis. Now how can you differentiate this specific thing? Definitely the diagnosis is not based on clinical features alone, so you have to go for various lab tests and all this, but clinically one thing which you can see is that later on this becomes a petechiae. Okay, initially it is an erythema which is very similar to what you see in viral infections, but later on the specificity of it is like it becomes a petechiae. Okay, it becomes a petechial lesion, slightly raised lesion rather than just an erythema. Okay, now that's about the specific symptoms, and definitely different bacteria will produce different types of specific symptoms, but here this is very important. Okay, if you see a question that is rash coming into petechiae, and if there is and definitely they'll give you some lab findings also, but this don't think that it's a viral infection, it is basically a meningococcal infection. Now if they talk about only rash and some other features, lab diagnostic features of viral infections, again don't confuse, it is a meningococcal infection. Okay, so that's very important. Now we come on to the very important part, which which is there in the charts and all this, which is diagnosis. So there are different ways to diagnose acute bacterial infections. Most important is to examine the CSF, or examination of the CSF is the most important thing which you can do by lumbar puncture. Okay, examination of CSF is the key. When it comes to viral infections, there are other methods also, but here its main thing is examination of CSF. Now what are the features you could see when you examine the CSF in a patient with acute bacterial meningitis? So most important is PMNL, or polymorphonuclear leukocyte, okay, or leukocytosis I would say. Okay, leukocytosis, that is neutrophils are okay, increased. You know that any bacterial, acute bacterial infections can cause, other than tuberculosis and all, any acute bacterial infections can cause the increase in neutrophils. So there's no much a problem. Now, there's going to be decreased glucose. How you can remember this is that the bacteria is going to consume the glucose. They love glucose. Okay, they are going to consume the glucose. So if there is a decreased glucose, it's going to be a bacterial. Okay, definitely there is going to be an increased protein, because I told you there is different inflammatory mediators which come, most of them are proteins, you know that. Okay, and as you all know, there's going to be an increased intracranial pressure and positive culture, because bacteria can be cultured. When you come to the viral infections, the culture usually it is culture negative. Okay, so there's going to be positive culture and also positive gram staining. Okay, we have studied this gram staining of like Streptococcus pneumoniae and Neisseria meningitis produces what kind of features. Okay, now this is basically the features of the bacterial meningitis on CSF examination. Now, a few more things which you have to note here is that there is a decreased glucose. What is the value of this decreased glucose here? The value is that you can explain it in two terms, that is millimoles or milligrams per deciliter. So it is 2.2, less than 2.2 millimoles, okay, less than 2.2 millimoles, or it can also be less than 40 milligram per deciliter. Okay, less than 2.2 millimoles, or what you have studied previously, 40 is a normal one, so less than 40 milligrams per deciliter. Now, the book says another methodology which you find the ratio of CSF glucose divided by serum glucose. Okay, CSF glucose divided by serum glucose, you will see that it is usually less than 0.4. Okay, it's a ratio, so there is no unit, less than 0.4. So this is very typical, except seen in other meningitis also, but slightly more typical towards the bacterial meningitis. Okay, so what you need to know, there is the level of glucose is less than 2.2. More importantly, for an Indian system, it is less than 40 milligram per deciliter, or the ratio is less than 0.4. Definitely, because serum has got more glucose. Here, the CSF glucose is further coming down, so it's going to be a ratio which is slightly less than 0.4. Okay, now there is going to be an increased protein. How much is this? It is greater than 0.45. So 0.45 gram per deciliter, gram per deciliter, or greater than 45 milligram per deciliter. Okay, so we know that the normal value is definitely up to the range of 50. So if it is greater than 45 or even greater than 50, it is going to be high protein. They're not going to ask you values most commonly. They're going to ask you what happens. Now, there is going to be an increased ICP, which is greater than 180 millimeter of water, which we have studied. So more importantly, I personally think this is a very important question. CSF bar serum ratio less than 0.4 is suggestive of, considering also the symptoms and all those, suggestive of this. And when you consider this, you also consider the PMNLs, because there is another thing which I'll discuss you. There is another meningitis which also produces less than 0.4, but their results are not PMNLs. We're going to see that next. Okay, that is okay. Before that, there is some other test which you can go for, specifically finding specific microorganisms, of which the first one is latex agglutination test, which is for the two typical ones, which is Streptococcus pneumoniae, we studied, the most common cause, and Neisseria meningitis. There's also other bacteria which produce this positive latex agglutination, but the sensitivity and specificity for these tests is very high for Streptococcus pneumoniae and meningitis. So they will ask you only this. Now there is another test which is Limulus amoebocyte lysate assay, or you can call it as Limulus lysate assay. Okay, Limulus lysate assay. This is to find out gram-negative endotoxin. So if a gram-negative organism is causing this disease, okay, then you can find, if you're suspecting like that, you can go for this Limulus lysate assay, and if it is positive, that means it's a gram-negative endotoxin is there, which is LPS. Okay, and you can specifically find this. Now, few more things. I told you, if it is PMNLs, and decreased glucose. If it is PMNLs, decreased glucose, what is the diagnosis? The diagnosis is bacterial. Now, if you have lymphocyte instead of neutrophils and the glucose is normal, remember this, if you have got lymphocyte, okay, and if you have got normal CSF glucose, which is not decreased glucose, okay, then the diagnosis is viral meningitis. Okay, remember this. Before going on to all those charts, I'll tell you this. This is very typical to diagnose, because definitely they will tell you what type of cell is there and they're going to tell you what is the glucose level. So if it is neutrophils, okay, if it is neutrophils and the glucose has come down, it is bacterial. If it is lymphocyte and the glucose is not coming down, it is going to be viral. Now, again, if it is the same lymphocyte only, but the glucose has come down here like the bacteria. So again, it's something related to bacteria because bacteria is eating it. So one typical one is tuberculosis. Okay, tuberculosis. Okay, fungal meningitis. All this comes into acute. Both of them come into subacute meningitis. Acute is the ones which we are discussing now, also the viral, which is also acute, but subacute is tuberculous meningitis and fungal meningitis. Okay, and it can also seen in carcinomatous meningitis, which is chronic meningitis. Okay, so this is thing they can ask you, what is the type of cell? The type of cell is the neutrophils. Okay, and glucose has come down because bacteria has eaten it, so it's bacterial. Now lymphocyte, that means itself which says you it's viral. But the problem is there should be a normal glucose. If glucose is coming down and you have got lymphocyte, it has these three: tuberculous, fungal, and or carcinomatous. Okay, so this is basically understanding of acute bacterial meningitis. The other two meningitis is not so much detailed. Just to understand your pathophysiology and all, I've gone a little bit of detail. Okay, a quick review of what we have studied so far. Basically CSF pressure, glucose levels and all those. Okay, what is much more important is the infection of the infection and inflammation of meninges is what is meningitis. Okay, then you have got acute and subacute and chronic. Acute includes bacterial, viral. Acute bacterial, it's basically, I've told you, it is the suppurative infection, the most common suppurative infection of CNS, which is the suppuration is seen in subarachnoid space. Streptococcus pneumoniae, adults, community acquired, CSF leakage associated. Then Neisseria meningitidis is second most common. Other organisms, group B, which is Agalactiae, which is neonates and greater than 50. Monocytogens, neonates, pregnant, immunocompromised and greater than 60. Pathophysiology, very simple: epithelial cells, nasopharynx, okay, blood, choroid plexus, CSF, and in that lysis of bacteria, large release of the contents, which is the cell wall contents, cytokines, inflammation, manifestations. Okay, then you have got what are the manifestations: increased permeability, edema, leakage, obstructing the flow, increased CSF pressure. Both together can bring about cerebral herniation, and also the inflammation can cause death of the brain cells, which especially dentate gyrus of hippocampus. Clinical features very important: triad of fever, headache, and nuchal rigidity. And nuchal rigidity is very pathognomonic of meningeal irritation. Two signs also we studied about meningeal irritation, which yes. Then decreased level of consciousness, nausea, vomiting, photophobia, seizures, yes, raised ICP. And a very classic sign of increased ICP is Cushing's reflex, which is bradycardia, hypertension, and irregular respiration. Two signs, which is Kernick's sign and Brod-Sansky's sign. Remember these two images, Kernick's and Brod-Sansky's. Then specific meningococcal, rash of meningococcus, which can later becomes a petechiae. So that gives, that differentiated from viral infections. Diagnosis: examination of CSF. So you see is the PMNLs. Okay, glucose is going to come down definitely and less than 0.4, very important. Okay, the ratio is less than 0.4. Protein increases in all cases, raised ICP in all cases, positive culture, yes, which is not seen in viral. So if they tell you there is a positive culture in the question, it's much more towards either the acute bacterial or subacute, which is tuberculosis also is a bacterial infection. Again, you have to differentiate tuberculosis because there it is lymphocyte, here it is neutrophils, isn't it? So then you come on to other test latex agglutination for streptococcus pneumoniae and N meningitis, Limulus lysate or Limulus amoebocyte lysate assay, which is 4 gram negative endotoxin. So as I've told you, if there is a lymphocyte and normal glucose, it is viral. If lymphocyte and low glucose, it is tuberculous, fungal or carcinomatous. In the next session, we'll discuss the viral infections and viral meningitis and subacute meningitis. So viral is acute meningitis, acute viral. Then we'll go on to the subacute meningitis. Okay, so that's it for this session. See you in the next session. Goodbye.